Today, my topic starts as tackling the challenge of managing persistent hypoglycemia in type 2 diabetes patients. I would walk the talk as long-term durable glycemic control, how it's a difficult goal to achieve, guideline recommendations and steps to achieve the glycemic control, considering why we should consider a DPP-4 inhibitor as an effective add-on therapy, for example, Vildagliptin, and why we would also consider it safe, and then would like to summarize the entire. So, as we all know, that 76.6% of type 2 diabetic patients in India have poor glycemic control. Despite the presence of guidelines, now India-specific guidelines, despite the presence of well-defined treatment in majority of the people, the disease is poorly controlled. Long-term durable glycemic control, again, is a difficult goal to achieve. So what does RSSDI, the Indian body, set as guidelines? They say that if glucose targets are not achieved with 2 agents, start third oral agent, which is either a DPP-4 inhibitor, alpha glucosidase inhibitor, SGLT2 inhibitor, or TZDs, depending on the second line agent already being used. Again, like the American Diabetes Association, they have put in a line for starting insulin or GLP-1 agonists. The ultimate goal they have set is achievement of glycemic control with minimal side effects, for which there are 2 steps: the setting up of individualized glycemic targets, and step 2, choosing the right add-on. So how to set individualized glycemic targets? This is the cornerstone of managing type 2 diabetes as per RSSDI guidelines 2020. Fasting plasma glucose should be ideally between 100 and 125. 2 hours plasma glucose during 75 grams oral glucose tolerance test should be 140 to 199, and A1C should be 5.7 to 6.4. Glycemic targets must be individualized, and in the process of individualization, it should involve a shared decision making where the patient is also a part of the decision taken about his treatment. The ADA 2021 approach to individualization of glycemic target says that good glycemic control is reflected by A1C, which remains the foundation of managing type 2 diabetes. A reasonable A1C goal in an adult with type 2 diabetes is less than 7. Individualized approaches play a vital role in preventing or delaying the onset and progression of diabetes complications. However, here we should definitely add that today a different concept, something beyond A1C, something beyond the glycemic triad is being discussed well. And yesterday you have heard Dr. Shomik Goswami talk about time in range. Again, time in range that is between 70 and 180 should be for 70% or greater time of the day. And well, however interesting and however insightful it might look, till today, measuring time in range in clinical practice is expensive and the devices are not accessible. So for the time being, I think we have to stick to HbA1c till time in range is more established and the devices by which we can look at the time in range become more accessible and affordable for the care provider. So how do we choose the right add-on therapy to help patients reach their glycemic targets? The therapeutic armamentarium of oral anti-diabetic agent has expanded its horizon. Sulfonylureas in 2005, and now in 2020, we have 7 major classes of OHs, including DPP-4 inhibitors and SGLT2 inhibitors. With the increasing number of available medication choices for diabetes, patients are being managed with a greater number of classes of medications in combination. But yet in India, if we have a look at the data, we would see the first 5 combinations with metformin are different forms of sulfonylurea, and the glimepiride sulfonylurea, economically speaking, they have captured 1/4 of the oral anti-diabetic combination therapy market. So what are the considerations when you choose an add-on based on outcomes and adverse effect? The immediate outcomes being glycemic control, body weight, lipid levels, LDL, HDL, cholesterols, and triglycerides. For example, the long-term outcomes would talk about cardiovascular risk and mortality, the microvascular outcomes, and also the all-cause mortality. And the adverse effect would consist of the GI intolerance and, of course, the hypoglycemia, and the epitaph of everything would be severe and nocturnal hypoglycemia. So while we address the complexity of choosing the most effective add-on therapy for a type 2 diabetic patient and controlled on a sulfonylurea metformin combination, that being the most predominant combination being used in India, so what would be the characteristics? The effectiveness of an add-on to sulfonylurea and metformin can be considered based on whether it can achieve glycemic goals. Is titer control beneficial, and can it be achieved without an increased risk of hypoglycemia, especially amongst the elderly? And will the treatment improve the beta cell function and thereby improve outcomes? RSSDI 2020 regarding triple therapy talked about patient-centric approach, and they said that if glucose targets are not achieved with 2 agents, a third oral agent may be tried, and I have talked about this in a previous slide. The various choices for an add-on oral therapy could be after sulfonylurea and metformin, could be DPP-4 inhibitors, SGLT2 inhibitors, TZDs, and AGIs. Now let's see a comparison between them. If you look at DPP-4 inhibitor as an add-on oral therapy over TZDs and AGIs, we would see the key advantage over TZDs and AGI is the highly favorable tolerability and weight neutrality. So DPP-4 inhibitors here fits the bill of an effective yet safe therapy. When choosing an add-on, the clinician's mantra should be prius minus nocere, which means first do least harm. The key advantage of DPP-4 inhibitor over SGLT2 inhibitor is its highly favorable tolerability. You don't have to really look at UTIs, GMIs, etc., about postural hypotension, about the chances of limb amputation. And so the DPP-4 inhibitor is just like a fill it, shut it, and forget it drug. And thus is an effective yet safe therapy, especially among patients on polypharmacy. So why do we consider a DPP-4 inhibitor as Vildagliptin as an effective add-on therapy? Vildagliptin, as we see that it significantly improved glycemic control in patients with type 2 diabetes, inadequately controlled with metformin and glimepiride combination. The mean change in A1C was greater with Vildagliptin compared to placebo. HbA1c reduction was 1.01. and the treatment difference was statistically significant. And if you looked at patients who achieved their glycemic targets, when Vildagliptin was added on to sulfonylurea, was in overall population, it was jumped from 5.6 to 28.3 with a Vildagliptin 50 milligram twice daily, and for whom the baseline HbA1c was less than 8%, it was an increment of 13.9 to 38.6%. In triple combination with sulfonylurea and metformin, it showed clinically relevant HbA1c reduction of about 1% and robust fasting plasma glucose reduction of about 1.1 millimoles. Patients on Vildagliptin also showed improved beta cell function, improvements in the AIR glucose and A index, increased disposition index by 69% indicate improvement of beta cell function with Vildagliptin, and there has been nearly 5-fold enhancement of beta cell function when Vildagliptin was added to metformin. Vildagliptin thus can be said to enhance beta cell secretory capacity, and thus it ticks all the boxes for an effective and well-tolerated add-on therapy. Efficacy as an add-on therapy by HbA1c reduction, improvement of beta cell function, and effective and safe in the elderly. So that is about efficacy. And let's look at safety. Moving beyond glycemic control, the RSSDI 2020 guidelines talked about patient-centric, evidence-based approach for management of type 2 diabetes. And the safety profiles to consider consist of the weight impact, the hypoglycemia risk, and also keep in mind the considerations. The Vildagliptin in triple combination is weight neutral and associated with a low risk of hypoglycemia, as is seen by the mean change in body weight is less than 1 kg. It's about 500 grams, and only 5.1% patients said to put on the weight, and lower risk of hospitalization due to heart failure with Vildagliptin in comparison with Vildagliptin, saxagliptin, and sitagliptin. This is a study by in the International Journal of Heart Failure from Chang et al. But it's a little bit debatable with a real world evidence of about 2.39 lakhs. Vildagliptin had 0.74 as a hazard ratio, and the upper bound of the confidence interval was 0.81. However, it is not supported by the cardiovascular outcome trials, as sitagliptin proved to be neutral in TICO's trial, and saxagliptin had a 1.27 hazard ratio with regards to hospitalization due to heart failure. And Vildagliptin for itself did not have a cardiovascular outcome trial. No change on left ventricular ejection fraction with Vildagliptin. This is from the VIVID trial, where although the end systolic and end diastolic diameters, they did increase without decrease in left ventricular ejection fraction with Vildagliptin in comparison to placebo. These are the summary of the key cardiovascular evidence on Vildagliptin this is the second one is the VIVID trial, and it got the 254 patients, Schweitzer et al., 25 phase 3 trials, greater than 13,000 patients, and McInnes et al. In 2015, 40 phase 3 and 4 trials with 17,000 patients, Chang et al. With greater than 2 lakh patients, that's the real world evidence that I talked about. Williams, 7 lakh patients. Vildagliptin showed no increased risk of adverse cardiovascular events compared to the anti-diabetic drugs. And then Fadini et al., 17,000 patients, no difference in incidence rate of first and total hospitalization heart failure events with Vildagliptin compared to sulfonylurea. Vildagliptin thus ticks all the boxes as a safe add-on therapy, as it had recorded low hypoglycemia events. It is weight neutral, and even without a CVOT, with such robust numbers being included in the real world evidences, it can be said to be CV safe. And also in low ejection fraction with NYHA scores of 1 to 3 in the VIVID trial, it showed that addition of Vildagliptin did not alter the LVEF in any way. So we can consider a DPP-4 inhibitor like Vildagliptin as an effective and safe add-on therapy across various patient populations, especially in the elderly and in the renally impaired. Vildagliptin was effective and well tolerated in elderly type 2 diabetes patients, and elderly patients with a mean age of 77 years were on Vildagliptin add-on therapy showed a relevant HbA1c and fasting plasma glucose reduction. HbA1c reduction in the age greater than 75 years was 1.08%, and the age less than 75 years was 0.9%. Fasting plasma glucose was reduced by 1.24 and 1.36 millimoles per liter, respectively. And if you looked at fasting, HbA1c, and the body weight, and looked at hypoglycemic events, if 0.9 to 1.2% A1C reduction, 1.1 to 1.2% of fasting plasma glucose reduction, and body weight reduction by 900 grams and 0.4. Most importantly, body weight did not increase. Hypoglycemic events, very important, any events less than 75 years, 0.3%, negligible, and in greater than 75, it was 0%. And if you look at the severe hypoglycemia, that was the, concerning for us, that is 0% in both the age groups of greater than 75 and less than 75 years. So adjusted HbA1c and mean change from baseline from week 24 and 52 in patients with moderate and severe renal impairment receiving Vildagliptin or placebo. So this is the moderate renal impairment in the left-hand side. And as we can see that the adjusted mean change is more than in the Vildagliptin group rather than in the placebo group. And the between group difference is statistically significant in the severe renal impairment group, where the Vildagliptin reduced it by about 0.9%. And in the placebo group, there wasn't a statistically significant reduction. But we must remember that below an eGFR of 50, Vildagliptin has to be used as an OD dose. So Vildagliptin is safe as an add-on for type 2 diabetic patients with moderate and severe renal impairment. None of the adverse events were severe, suspected to be drug-related, or led to discontinuation. So if you look at moderate renal impairment, you would see that any adverse event, any severe adverse event was comparable in the Vildagliptin 50 milligrams group versus the placebo group, of course 50 milligram once daily, and any adverse event leading to discontinuation was 4 in the Vildagliptin group, and in the placebo group it was 7, and deaths were similar, 1 and 1. And in the severe renal impairment group, you had 72.6 adverse events in the Vildagliptin group and 74.2% adverse events in the placebo group. Severe adverse event was 23 versus 20. Any adverse event leading to discontinuation was 11 and 6, and deaths were 3 and 4 respectively, a little bit more in the placebo group, but not statistically significant, however. So Vildagliptin again ticks all the boxes as a safe and effective option for add-on therapy across patient population. And in summary, we can say the advantages of add-on Vildagliptin. We all know from the verified trial that Vildagliptin and metformin, if we use it in the beginning, at the start of the disease, it had immense benefits. We have all discussed it and listened to it in several CMEs before coming out here. But here we have discussed Vildagliptin as an add-on to sulfonylurea and metformin. It showed better efficacy, beta cell preservation, safety profile with low risk of hypoglycemia, natural weight on weight gain, neutral effect on weight gain, well tolerated amongst elderly patients with cardiovascular disease, renal impairment. And in conclusion, we can say, despite good initial efficacy of dual combination of sulfonylurea and metformin, sulfonylurea failure is a known issue. Many patients require an additional add-on therapy over a period of time. And as we discussed that about 75%, more than 75% do not achieve targets. DPP-4 inhibitor as a second add-on therapy can achieve significant glycemic improvement. And here we have to remember, the later we add the drug, usually the HbA1c benefit or the reduction benefit goes on to be less. But Vildagliptin, despite being put on as a second add-on to metformin, first add-on being sulfonylurea, had produced nearly about 1% of HbA1c reduction. It is more effective DPP-4 inhibitor amongst all gliptins when used in twice daily dose. That is how some of the studies put it. And Vildagliptin as an add-on to metformin and sulfonylurea was found to be effective and safe even in Indian patients. That is very reassuring that in the genotypes and the phenotypes that we treat, it has been effective as an add-on to the most widely used combination therapy, that's sulfonylurea and metformin. So in clinical practice, probably we are likely to encounter somebody on sulfonylurea and metformin failing to achieve targets coming to us. And there, Vildagliptin, with the data that I have presented, presents itself as a safe and efficacious therapy as a second add-on, and is usable even in elderly subjects and in patients with renal impairment. But it is to be remembered that in patients with renal impairment of eGFR less than 50 ml per minute, it is to be used as once daily. Thank you so very much for your kind attention, and I would be happy to take in questions.
Thank you, Shomo, for such a lovely session, for such a lucid talk. Probably one thing coming up, that despite of not having a dedicated cardiovascular study, Vildagliptin has probably established its place over last 12 years of clinical usage. Would you like to re-emphasize this issue that we often look for CVOT data and we often look for CVOT safety cum superiority data while choosing any molecule? But we've been happily using Vildagliptin over last decade, even without any dedicated CVOT thing. Though we had some pooled EMA data regarding Vildagliptin. What will be your comment on this thing? Requirement of CVOT for all molecules.
Actually, we had started to use Vildagliptin and even before the other CV outcome trials had come to the market. And with our regular use, I was not possibly practicing diabetes at that point of time. It had gained the confidence of our peers and stalwarts of the field, due to which, even without CVOT data, due to its efficacy and convenience of usage, due to its the DPP4 characteristic of being a fill it, shut it, and forget it nature. And most importantly, what I emphasized in the talk, that even after addition to sulfonylurea and metformin, which was possibly the commonest OAD combination that the patients were on at that period of time when Vildagliptin and sitagliptin had come into the market, they had produced enough of A1C reduction. And as we know from the UK PDS, which is the Bible of type 2 diabetes, that HbA1c reduction can result in some benefits, whether it be microvascular, which is evident pretty early on, and later on we came to know that yes, if you follow up the patients for long enough time, a good HbA1c reduction being in control does produce macrovascular events as well. And to be frank, I think Professor Majumdar is also there. Despite without being a CVOT savvy DPP4 inhibitor, really did we see many heart failures due to a DPP4 inhibitor in our clinical practice? You are also there. Please comment. How many? How many did you see?
Somo, I fully agree with you. Our personal opinion or our current understanding about this molecule, and we are using this drug for almost 15 years, and we have rarely seen any precipitation of heart failure with the use of Vildagliptin. On the other hand, I can vividly remember some of my patients who developed heart failure after the rosiglitazone therapy. So we can definitely clinically distinguish with our experience that Vildagliptin appeared to be very safe. Having said that, there is some question is raised because of the fact, in the VV trial, we have found that there is somewhat increment in the left ventricular volume. But we don't.
But without any impact on the left ventricular ejection fraction.
Yes, without any impact on the left ventricular ejection fraction. But we don't know the significance of the increase in the left ventricular volume. As far as the heart failure data and the data what you have shown, that it has decreased the heart failure issue, even with compared to the sitagliptin.
Well, I did not. This is a company presentation, and I had given my disclaimer that this is contrary to the.
But this kind of data is there. I am not telling the data is not there. Data is there. Also, the reverse data is also there. That as a group, DIP4 inhibitors have shown some increment in the heart failure. So there is a little bit of controversy, though the CETA and the Vildagliptin has actually cleared doubt because they had done a dedicated cardiovascular outcome trial. We have seen somewhat increment in the heart failure risk, though not statistically significant with allogliptin. So as a matter of fact, the heart failure issue is still with the DIP4 inhibitor.
As well.
So Vildagliptin, as because
or even the one
yes,
aid to you. If you really look at the real world evidences, and if you look at the distribution of the real world evidences, the Italian data, real world evidence which came out, which showed that there is no increase in heart failure with any one of the gliptins. However, once you're including the American data, perhaps you are having an incidence of heart failure. Why is this difference? I fail to understand.
Probably the definition is not uniform. Probably the definition on cutoff is not uniform.
Oja has rightly pointed out that may be the answer, because you can see that in the heart failure, whatever the study, the definition of the heart failure in different study is different. Well, if I remember correctly, in one of the study they have taken the heart failure if it is observed or if it is actually recorded in the emergency. That's it. There was no need to look into at this.
I know there was no biochemical or echocardiographic.
BNP was not included.
Yeah, at that point of time,
BNP was not included in many of the studies.
Was not actually taken as a important surrogate marker as far as the heart failure is concerned, the diagnosis is concerned. So we are really a little bit doubtful. But Shomu, I think we have one question in the chat box, and that is very important, that where you will not write Vildagliptin. So do you have any area of concern where you will not write it? Because you know that the physicians want to know this, that they often write Vildagliptin with the understanding that it is one of the safest molecule we can write as far as the diabetes management is concerned. But we must know that where is your concern?
There are two things that I would like to reiterate. If the LNI, SGOT and SGPT is more than 3 times the upper bound of normal, that is a contraindication that's included in the PI also, I suppose. And second, regarding the dosing, I have repeatedly said that once the eGFR is less than 50, Vildagliptin should be used once a day. And now with the availability of the OD formulation, perhaps 50 OD could be a choice. And in such a scenario.
Okay, so I think
anyone having a history of diarrhea with a reason to suspect pancreatitis, or a young person where I'm excluding gallstone or pancreatic disorders, I would be double cautious. I should be double cautious. Whenever I'm listening something suggestive of pancreatitis, using incretin-based regime would definitely put me at risk. I would like to have a very quick questions to Dr. Anirban Mojumdar, because it's always very enriching experience to hear him. Very two quick questions. Number one, we all know that these molecules are going off patented and lot many congeners are coming up, both gliptins as well as SGLT2 inhibitors. Are we seeing the next phase of clinical prescription where we are keeping sulfonylurea aside because of the economic version of gliptin and DPP4 inhibitor, along with SGLT2 being now available as a very affordable minimum? And second question is, where do you put DPP4 inhibitor in quote-unquote SGLT2 era or peptide in a pill era, the way you define it?
Yeah, I think giving you the answer to the last question is that it is just price issue. Otherwise, you can write DPP4 inhibitor or the oral GLP-1. So where the patient actually can afford, and GLP-1 definitely will be better because it will have
the physiological advantages beyond the physiological
limits and also the cardiovascular benefit. So GLP-1 definitely better than the DPP4 inhibitor, as a matter of fact. Now the price is basically true. But coming to your first question, I'll give you a brief understanding that how we are managing diabetes nowadays and how we would like to see it to be managed by the physicians. That from the very beginning, it is better that we actually try to cover all the 8 pathophysiological defects of the diabetes. So when a diabetic patient come to us then usually nowadays for the last few years, I have started using all 2 or 3 drug agent simultaneously. And therefore, when you are using 2 or 3 drug from the very beginning, you should be very cautious about the hypoglycemia. So quite naturally, the sulfonylurea will not be one of the choice as far as this regime is considered. So either I'll give a metformin plus PIO plus SGLT inhibitor, or I'll give metformin plus PIO plus DP4 inhibitor, or I'll give metformin plus DP4 inhibitor plus SGLT inhibitor. So something like that. So drug, 2 or 3 drug combination from the very beginning, which will not produce hypoglycemia. So therefore, as you have rightly pointed out, once we all the major D4 inhibitors and the major SGLT inhibitors are off patented, the pattern of prescription I expect will change, and the physicians and those who are actually practicing in remote areas will be benefited both as a patient and also as a physician, because they don't have to face the important issue, that is hypoglycemia, with the use of combination of 2 or 3 agents simultaneously from the very beginning. So I think Somo, Ajay,
thank you so much, Anirbandha, for such a very nice thing. Can we request Dr. Sombroto Raichudhuri to take over the session and request our next speaker? I think Dr. Rana Bhattacharya has already logged in. And can we move on to our next session?
Dr. Rana, thank you, Ajada, for moderating the session and asking me so many questions, and many of them pertinent to our day-to-day practice. And I think we would just take a comment from a small bite about the conference from Dr. Sudeep Chatterjee before we move on to listen to Dr. Rana Bhattacharya, who is going to refute Dr. Majumdar and say what, how, and when we should use sulfonylureas in day-to-day practice.